You're listening to Aging Uncensored.
Welcome back. Good morning. Welcome to Aging Uncensored. I'm Shaylee Lawson, your host today. And welcome. This is Aging Uncensored, where we talk about all things aging. Nothing is off the table here. And we're super excited to have a really special guest today. It's Lance Lee. And I've known Lance, for several years now. And Lance is a community educator with ExpectCare Hospice, which is a local hospice group that's been near and dear to me and served quite a few patients of mine, and has done a beautiful job doing that over the years. And I couldn't think of a better person to have than Lance to join us today and talk a little bit about hospice. I know it can be sort of a taboo subject. So my goal here today is for us to be able to talk through some of these tough topics, really deep dive into what hospice is, who benefits from it, the services. The services are unmatched. And hopefully maybe break down some of those barriers and help people learn and educate others on what hospice is and how it can serve our dear patients and families.
Absolutely.
So welcome, Lance. We're happy to have you.
Glad to be here. Thank you so much, Shaylee.
Yeah.
Thank you. Hospice is dear to my heart. I've been in hospice services almost 20 years.
Oh my gosh, long time.
Long time. I found out at that time that I'm passionate about hospice, because it's so misunderstood.
Yeah, agreed.
And what we say is the most underutilized healthcare service that there is, that's available to us, that we all have available to us, and people don't know about it.
Yeah.
Or they don't know when to ask for it, or when
Right.
it's appropriate for themselves or for their loved one.
Providers don't know that either.
Well, providers, absolutely, no one in the community. I learned that very early. Providers, are some of the most difficult ones to educate, just because of time and having interaction with them in their clinics or whatnot. It's very limited.
Yeah.
But we're working toward that, at ExpectCare Hospice. My role is to educate, and my role has evolved over these last 20 years. First started in hospice, I was the volunteer manager, coordinating volunteer services to our patients and families, and then kind of transitioned along with that to chaplain and bereavement services for several years, where I did work very directly with patients and caregivers at bedside and helping them through, just a difficult journey of life, end of life care.
Yeah.
And just was blessed by all of those opportunities and every day that I have with patients and families. And I guess in the last 8 to 9 years, I transitioned into more of an education role, working with kind of the first point of contact, working with patients and families in the community who have questions about hospice, who may have heard that their loved one possibly could benefit from hospice. Someone has introduced that idea to them, but they still have reservations or fears, misconceptions about hospice. And so what I love doing is just meeting with the patient and their caregiver wherever they are. If it's in their home, at bedside, around the kitchen table. I've sat in situations like this where we just have the whole family around the table that have questions about hospice. We might be there as early as 45 minutes, but I've been in a home, depending on who is, how many is around the table, up to 4 hours.
Oh my goodness.
Because I want to make sure everyone's questions are answered. And that they're at peace about the decision they're about to make.
That's right.
And that there's no misconceptions or misunderstandings. But once they realize, oh wow, that's what hospice does, or I get this with hospice, that we're going to talk through today, they're like, yeah, that's something I feel like I need and I want. When do we get started? And then I just help them through that transition.
Yeah.
So.
Yeah, I know that I've had patients in the past that I have recognized would benefit from hospice and maybe just haven't been quite ready or, haven't been ready to say yes to that service. And I know I've reached out to you and, you've helped a lot with some really special cases of mine. So,
well, and it starts, someone plants the seeds, we just keep planting the seeds or watering the seeds. And typically, what I've seen over the years, it takes multiple conversations, beginning with their provider, or a physician in the hospital, or the medical director at the nursing home. But I want to be a resource to you and your team, Chaley, and also to the patient and family. Just coming alongside of them, spending that time, however long it takes. For them to be ready.
Right. So agreed. I mean, at the end of the day, we want to do what's best for the patient and for the family, and as long as that's our Northern Star and our goal, we'll get there.
We will.
I know I'm not going to spend a lot of time talking about this, but I do want to kind of address it in the beginning. I know there's a couple of different phrases that get thrown around, and maybe people don't always understand the difference between hospice care and palliative care. Sometimes they're used interchangeably, and for the purpose of this conversation, I want to differentiate the two of those on the front end, so that way we could have a whole podcast on palliative care. Palliative care is wonderful, but essentially, for today's purposes, palliative care is care is symptom control care. So it's for people who can be any age, have any kind of disease process. They may have cancer and be undergoing chemo. They do not have to be end of life. They can be seeking, extensive therapies or invasive treatments, all of that. It's about what treatments can be offered to control their symptoms from whatever disease that may be. So if it's cancer and you're going through chemo, you may be seeing a palliative care physician or provider who is helping you navigate nausea or poor appetite or weight loss or anything that's related to that disease. Even that you're seeking curative treatment, but you still need support from a symptom and quality of life standpoint. It may be someone who has brain changes and dementia, like we talk about a lot, and maybe they don't quite meet the guidelines for hospice just yet. We know there's not necessarily anything that we can do there may not be an invasive therapy available, but we may be using medications to help their anxiety and help their quality of life and the symptoms that are related to their dementia. So that's palliative care too.
Absolutely.
So palliative care at its core is just symptom management. That is it. And in hospice, we use palliative care because we manage patient symptoms, but hospice is a comprehensive service that's going to include some palliation or palliative care because we're managing symptoms related to their disease process, but it's also going to include a lot of other services and is really meant for people who when I'm telling patients, I don't often say end of life. I may in certain circumstances, but because I like for patients to be able to get on hospice as soon as they qualify and be on hospice for as long as they possibly can, I always say hospice is for when we have a disease process that we know is not going to get better. And we want to focus on doing things for the person rather than doing things to the person. And that's kind of how I present it. And with hospice, the guidelines say that the reasonable expectation is according to this person's disease and the natural progression. We would anticipate that they would pass away in 6 months. But no one knows that for sure.
Absolutely.
And people can stay on hospice for a lot longer than that, right? I see it all the time. So it's really about caring for people who have an advanced disease state, obviously have some symptom burden from that, have some family, there's caregiver and family support that's needed. And it's a comprehensive service that provides all of those things together.
Right.
Does that make sense?
Absolutely. Typically when I'm explaining the difference from families, because usually when I'm meeting with a family, they've heard of the word palliative.
Right.
Someone has shared that word with them.
Mm-hmm.
And may not have shared hospice.
Mm-hmm.
I think a lot of times, and especially in our community, the greater Birmingham community, we've started using the word palliative as a means to be able to start opening up these conversations that are difficult conversations to have with patients and their caregivers. So we might use palliative as a softer word to be able to start the conversations, but there's advantages obviously to that. The disadvantage to me is muddying the water with the word hospice.
Right.
Is because, as you mentioned, it is two different specialized services.
Mm-hmm.
And I like the way you put it. Palliative care is available at any stage, any age,
Absolutely.
for any symptom burden, and it could be where the patient can recover.
Absolutely. Yeah.
That's something that happened acutely or suddenly, and in the chronic stage. But when I'm talking to families about hospice, usually I present it similar to you, Chaley, in the sense that it may not be end of life, but I talk about end stage disease progression.
Yeah.
Or a life-limiting illness. Most people understand or have heard from their provider that they have end-stage heart disease or end-stage dementia, end-stage COPD, or a stage 4 of some type of illness. So they understand that they're at the latter stage and phase of their illness.
Yeah.
So I present and begin there, because a lot of times, as like you, trying to get them to be receptive to hospice earlier, if they could be eligible for hospice at the beginning of the end stage process. It's just Medicare, Medicaid, all of our insurance programs. Most people don't realize they have a hospice benefit.
Yeah.
That's what I first also talk to families about is,
what is this going to cost?
what is this going to cost me? I had that the other day. Does this cost me anything? No, hospice is covered 100% by your insurance. Major medical insurance pays for hospice. There's no co-pays for anything that I know we're going to talk about, our services and all the benefits. I have a hospice benefit under Blue Cross Blue Shield. And of course, I've worked in this field for several years, and I know when to ask for it for myself or for my loved one, but it's available to us. And I know that if anyone in my family has a life-limiting illness, then we're in that latter stages, we could begin to talk and think about hospice and when to introduce it to really get the full benefit of the hospice coverage and services and the comprehensive care that you mentioned. So that's how I kind of start the conversations with patients and families is, tell me a little bit about where your providers, your doctors have told you where you are in this disease. And I have had patients, who are very detailed oriented or like research and kind of do their own research, and they'll research hospice, and if you go out there and you look at the Medicare,
Medicare.gov,
which is very informative, and it will state if the disease takes its normal course of action 6 months or less. And so sometimes families get hung up on, well, my loved one's not going to die in 6 months.
They may not.
They may
okay.
not.
That's
Absolutely.
Right. That's right.
That is okay.
That's okay.
As you said, it's the best educated guess that our physicians have. You know.
And hospice is not going to do anything to hasten that. We're not held. They're not. I'm not hospice. I'm saying we, but hospice is not held accountable. Like Medicare does not come knocking on the door and say, this person is still alive after 6 months. What are y'all doing?
Right. Absolutely.
That's not how it works.
And when I have families ask me about the 6 months or less, I'll usually say, no one knows.
Right.
We don't know. It's the best educated guess.
It's not up to us. That's what I say.
It's not up to us. It's not. But not only that, everyone has a different journey.
That's right.
Everyone has a different prognosis and journey.
That's right.
And so, and what we are able to do, if our patients live beyond 6 months,
Mm-hmm.
they're still eligible. They can still be eligible for hospice.
Right.
I tell the patients and families, as long as the hospice can document the progression of the disease
Right.
along the journey with them,
Yeah.
we can stay involved in the care.
Yeah.
And that's how it really, hospice sets us apart from home health.
Correct.
You know, home health is short term and focused on aggressive rehabilitation.
Yeah, it's restorative.
It's restorative.
So it's meant to be, you need them for a short period of
Right.
time because you're going to get back on your feet and get better, and then you're done.
Yes, you're done. Home health has to discharge and come out.
Yep.
Unless you need them again in the future. But with hospice, if you elect your hospice benefit, we can stay in the home, and as long as we can document the disease progression. So the earlier you get on hospice, and we've had families right now, patients who have been on our services for congestive heart failure or COPD,
Mhm.
or
Yeah.
even cancer sometimes for over a year.
Yeah, absolutely.
And people don't realize they can be getting that, our comprehensive care and the support
Yeah.
of helping them care for their loved one at home through
That's
the
right.
hospice.
We do not have to wait until, I mean, for lack of a better word, and because this is what people tell me sometimes, they're on their deathbed,
Right.
or they are, it does not have to be, we bring in hospice and they've got days left. Like, it doesn't have to be that way. We don't want it to
We
be
don't
that
want it to be
way
that
because
way.
we want people to get these services that they deserve. You know, I, in a part of my career, I took care of patients with kidney disease, and even when I was in the geriatrics clinic, I always did, like, especially if someone had what I knew to be a life-limiting illness, dementia or kidney disease or congestive heart failure, like to have that conversation early, you know, always having goals of care conversations and saying, like, when we get to the point to where you need more help at home and your goal is to be at home, and it doesn't make sense for us to keep coming back and forth to the hospital, or it doesn't make sense for us to do dialysis, then we'll have hospice at home. It would, that's what will help you have what you need and what you want. And we'd start that conversation way before. And it made a huge difference when I started that conversation early and engaged in that conversation, and then when it got to be time, because sometimes it can be time very quickly. You know, if I have a patient who has chronic kidney disease, stage 5, and they're not going to proceed with dialysis, but they, you know, they may be well compensated for quite some time, and everything's okay until it's not.
Right.
And usually it's not okay at like Friday at 5:30 p.m. You know, but we've already had the conversation. We've already talked about it. We already know what the goals are. I can call my friends at ExpectCare and say, hey, I got an admission for you. I need it done now.
Absolutely.
And so, like, having that conversation early, and like just saying the word, like, so that way, I don't want to say it desensitizes them, but like, don't be afraid to use that word, to use that terminology. Like, that's what it is.
Right.
Hospice is hospice, and that's okay.
Right.
Let's talk about some. I think that people don't know all the services that are
Right.
available in hospice. I think they think like, oh, a nurse is going to come out. We got that. Okay. Let's talk a little bit about that.
Absolutely.
Um,
So when I'm meeting with patients and families and explain the comprehensive care of hospice, typically they're already showing signs that they're having difficulty getting to their doctors.
Right.
You know,
Yeah.
and
big
you know,
piece
as
of it.
you know, as the disease is progressing, it's difficult to get the things you need, because what I usually say is, if someone's in the latter stages of their disease, you're going to start seeing a lot of symptom changes.
Yep.
It might just be monthly.
They might be subtle too.
They may be subtle, but it
Mhm.
might be monthly, but they could wake up this morning with, you know, something going on with it. They,
Mhm.
you know, say a shortness of breath, or if the heart disease, you know, fluid just builds up overnight,
Mm-hmm.
and they have to call their primary care provider or specialist. And typically, when you do a call, you have to leave a message, you know, and it takes them a couple days.
Don't get me started.
I know, well, it's just,
I know it's terrible. It
it's
is.
part of the process.
It is.
And,
It's hard.
And usually, I'll say, you know, that is That's okay for people like, me is going to the doctor for preventive care or
right.
chronic disease management.
Right.
But as we get in a later stage, things are changing.
Yeah.
More frequently than they
Right.
were.
You need more
You
like
need-
more personalized care, more like someone who's like laying eyes on you frequently to recognize changes
Absolutely.
quickly and be kind of ahead of that.
Ahead of that, and y'all do a great job of that because y'all provide that personalized care. What I've seen in typically what happens is they're calling, leaving a message.
Mm-hmm.
It takes a couple days for the doctor's office to call back, and if they haven't seen the doctor in several weeks or
So
months,
they need to come
they
in.
need to come in,
I
make
can't
a-
do anything till I see them.
right.
My
Listen,
first available appointment is in 2 weeks.
2 weeks. Well, by that time, they don't have the time to wait 2 weeks,
Right.
and they find themselves in the ER.
Yeah,
and
that's
then in the
right. Oh
hospital.
gosh, this is just
They're in the hospital.
makes me sick.
It does. And what I call the cycle.
Oh,
it
yeah.
begins to cycle.
That's exactly right.
And when you talk with patients, they'll tell you, I don't want to go to the hospital anymore.
No.
I,
Right.
I don't want to.
Right.
And so, hospice can help with that situation because
Mhm.
we bring the specialized medical care to your home.
Yeah.
And the way we can treat, all hospice is aggressively treating the pain and symptoms
Mm-hmm.
of the disease.
Right.
And we're able to do that more effectively because of the tools that we have available to us and the barriers that have been lifted.
Mm-hmm.
For instance, when you elect your hospice benefit, the hospice begins to manage the pain and the symptoms.
Mm-hmm.
Without hospice, especially if you're seeking pain management,
Mm-hmm.
The laws require us to see our physician face to face
Right.
to be able to get pain
Right.
management. And when you're electing the hospice, you eliminate all those barriers
Yeah.
because our physicians and our medical team comes to you.
Right.
And when our nurses are there on a routine visit, or we become your new medical 911, you call us in the middle of the night.
That's right.
Our
Call
nurse comes out
24/7.
24/7.
Yeah. And if your mom falls at 2 a.m. on Saturday morning, you call hospice.
You call hospice, we can come out.
That's right.
We can do mobile x-rays in the homes for our falls or
Yeah.
for chest x-rays. We bring medical care to you because all we have to do is call one of our medical directors and we can get prescriptions, equipment, supplies, whatever you need to take care of your loved one, to manage your loved one at home.
Mm-hmm.
The same day,
Mm-hmm.
within an hour, couple hours
Mm-hmm.
of our visits and your call. That's how we can take care of your loved one
Yeah.
and keep them out of the hospital, keep them out of the ER.
It very much
manage their
streamlines
symptoms.
their
It
care.
streamlines their care and makes it easier and supportive care for the caregiver.
Right.
Again, of having somebody just to call,
Right.
and being able to answer immediately or making a house call, the nurse making a house call and helping them through that situation
Yeah.
that they may have.
And hospice can still treat acute issues like
Yes.
infections,
Absolutely.
UTIs. I think that it's a decision between like what are the goals of the patient, what's the condition. Like if it makes sense to treat it, and we anticipate that treating it would help improve their quality of life or help maintain their symptoms better, then absolutely we would treat it.
Absolutely. And I think that is definitely one of the misconceptions of hospice, and you kind of alluded to it earlier. There's nothing that hospice will do that will hasten death.
That's right.
We don't stop providing care.
No.
We don't stop providing medications to treat
Right.
sudden, as you said, acute situations. If they need an antibiotic, ExpectCare, we're going to pay for the antibiotic. We're going to provide the antibiotic if they have an infection
Right.
or whatever it may be.
Right.
Wound care, there's a misconception now, we won't provide wound care. Well, at
Oh.
ExpectCare Hospice, we provide
Yeah.
aggressive wound care
Absolutely.
to the loved one. Because if it's all possible, we don't want the patient to die of the infection of the wound.
Sure.
It should be their disease,
Right.
that may be, but
It's
we're
a dignity
aggressive.
thing too.
It's a dignity thing
dignity
too,
about
and
like
pain.
it's holistic, it's total care.
Right.
Like, we're gonna do what makes sense from a symptom management standpoint, from a dignity and just being a
Absolutely.
human standpoint, you know. And I think that's what I have always loved about hospice so much, is like what you said, like, it just, so many barriers are just gone,
Right.
you know. And people do get a bit hung up sometimes, like, well, I still want to see my primary care
Yes.
provider, so tell me, like, if I'm on hospice and I still want to go see my PCP, is that possible? Can I do that? What is that? Or my cardiologist, or whatever it may be. What does that look like?
Absolutely, good question. I do receive that question a lot. Usually what I tell patients and families is that you still have a right to see your
Yep.
provider.
Mm-hmm.
A lot of times, you know, they're wanting to go see their provider really just to keep that connection.
Yeah.
There may be some things that the provider is able to do that in coordination with care with a hospice.
Yeah.
It's a coordination of care. We allow our patients to go to their provider,
Mm-hmm.
but we make sure that that provider knows that they're on hospice.
Right.
Because what happens is, it's more of an insurance thing. We want to make sure that the provider is doing what the patient wants.
Mhm.
If their goals are hospice care and focus on symptom management
Yeah.
and comfort care, then we want to make sure that that provider is also focused on that as
Yeah.
well. And that if they typically, you know, they go to their provider, they may suggest a new medication. Well, if there's a new medication that's suggested, we'll take that into consideration and we'll help the patient through that. And
Yeah.
it's okay to go to your provider,
Yeah.
but we have to, again, have those goals and say, why are we going to the provider?
Yeah.
And work with that provider within the hospice framework.
That's right. We want the provider that you're seeing externally to be part of the team, and
Yes.
not like you're just going to a provider and they're doing all these things that may
Right.
not make sense for someone on hospice,
Right.
and then it just becomes even more, the care becomes even more fragmented and
Right.
burdensome for the patient. And what I always tell people is, you certainly can still see your provider, but there also, if it's burdensome to get there, that burden is going to be removed
Right.
from you, and hospice can manage all of your needs.
Absolutely.
And a little bit, so the interdisciplinary care team.
Yes.
So let's talk about, I think hospice is really unique in the people that serve on that team. So obviously we've got our medical director, which is a physician. Typically patients will not see the physician face to face. Is that correct? Typically they don't see the medical director physician. They see their nurse on a regular basis.
Or nurse practitioner.
Or nurse practitioner.
Mhm.
And that, sometimes people get a little hung up on that,
They do.
but that is okay, everybody. Like,
Yes.
those nurses are skilled and very trained in, we're not making new diagnoses. That's
Right.
not what we're doing. We're not
Right.
doing, what they're doing is managing symptoms, recognizing when something's not right, reporting to the medical director, and then coordinating care with that medical director. We're not doing, wellness visits or labs, and it's because that's not always necessary. There may be instances where it is. It's never like a no never.
Right.
But in general, you don't have to see that physician face to face. You'll see a nurse practitioner, and then also we've got social workers.
Yes.
Is that right?
Absolutely. So it is, as we said earlier, holistic. Actually, this is one of the reasons that drew me into hospice years
Mhm.
ago is understanding that hospice guidelines, Medicare guidelines for hospice, is that it is interdisciplinary. It is holistic of the patient. It
Yeah.
includes, it's a requirement that not only the nursing for the medical care, immediately with hospice, you can get a certified nurse aide to help your loved one with the showers and bath, which is different than home health, because sometimes
Yeah.
in a home health, you're not able to have those.
Sometimes you can't do it
Yeah.
it's variable, and it doesn't last long, that's for sure.
In home health, it does not
It might
last
be
long.
like a 3 or 4 week situation.
But with hospice, you automatically have access to a certified nurse aide that will come into the home or wherever the patient lives and help with the baths and showers. You also have the social worker. The social worker is a very important part of the care. They're going to be helping you in assessing, definitely for caregiver burnout, making sure that the caregiver is supported, but Also, there may be other resources that the patient may qualify for under the VA, veterans.
Yeah.
So they're gonna be looking at all the resources in the community that the patient may be eligible for to help, again, support that patient, support the caregiver in the home. In addition to that, the chaplain. I mentioned to you that earlier I had the pleasure of serving as a chaplain for several years, directly as a chaplain. And so, spiritual needs need to be met at end of life, many times. And not only that, just having that, I always say, if you're someone of faith, additional prayer never hurts anybody, especially when we're going through difficult times. End of life is a difficult time.
And something about chaplains too, I didn't learn this until I had an experience at UAB as a provider where I had some additional education in palliative care and things like that, but chaplains are highly trained individuals. Chaplains, and not anything wrong with preachers, it's not like your country church preacher. That like chaplains are highly trained. Like I think that they're trained in a way and skilled in a way to be able to meet a variety of spiritual needs.
Absolutely.
They're not like evangelistic. Like they're not like going in and trying to like get you to adhere to their agenda. Like it is very much like spiritual support can be provided even to people who are not religious per se, or maybe don't have a certain belief set or whatever that may be, or maybe they have things they need to reconcile.
Absolutely.
It is a supportive role. It is not, people are often intimidated by it, but I just want to say that like all the chaplains I've met are incredibly kind, gracious, humble people who are purely just there for support.
No, I just think about one of our chaplains, just, his visits are really just going and visiting one of our patients who has dementia and dancing with her.
Oh.
She really can't interact verbally and communicate, and have, spiritual talks in that sense. But to me, that's spiritual.
Sure.
Because that's meeting her where she is right then, emotionally.
I love that.
And spiritually. So, but absolutely, chaplains are a very vital, important piece of hospice. And they're in another role, another person who's part of the hospice team is a volunteer.
Yeah.
And that's one of the things I love about ExpectCare, because we are community, family and locally owned. And we really put a lot of emphasis in our being community and growing our volunteer program. And we have several different programs, but our volunteers do wonderful things. And one of the biggest things I hear a lot is the caregiver needs a short break.
Yeah.
And so we have volunteers who can provide the caregiver a short companionship, a short break, let them,
go to a doctor's appointment.
Go to their own doctor's appointment, which they need to be taking care of themselves.
Yeah.
So it's very important for the caregiver's self-care. It could be it's just visiting the patient. We have patients in nursing homes who have limited family support, and our volunteers that visit with them may just sit at bedside, play music. We have volunteers who actually record our patients' life review in a little booklet, their life experiences from childhood to present.
Yeah.
We have volunteers, 2 specialized programs that I'm so excited about, that one of them is called Heartbeat Legacy Project, where we can record the patient's heartbeat and voice. And then with the help of Heartstrings Ministry, they can put it together to a keepsake, like a little stuffy or a little photo frame.
Love that.
I love it.
That's awesome.
We have volunteers who, from the Dreamcatchers Foundation, who will help fulfill our patients' one last wish or one first time experience, something they've always wanted to do in life, never had the opportunity. If they, like my dad, had to quit school early at 8th grade and go straight to work. So there may be a first time experience that the patient hadn't been able to experience that our Dreamcatchers will help them fulfill. So just the volunteers are also part of our team to help, again, support the patient and family in multiple different ways.
And I would say if you're a family member or a patient or anybody, you're looking into hospice and you're doing research about different groups, and we can talk a little bit more about this in depth, but I would ask, one of the questions I would ask is what is your volunteer program look like? Because I think some are more robust than others, and I think that's a huge resource and support, and that would be something I would want to know if I were looking into a hospice group.
Absolutely. And I'm biased because as I said earlier, part of my history has served as a volunteer manager. So that's always one of the questions I would definitely ask.
Yeah,
so.
Absolutely.
Mm-hmm.
And then let's talk a little bit about respite care. So one thing that we haven't mentioned is hospice can be available to people who are at home, or in a nursing home, or in skilled nursing, or in assisted living, memory care, really any level of care. Group home, I've seen hospice patients, I've done hospice in the past. I've seen hospice patients at hotels. Yes. I've seen them everywhere. Oh my gosh, anywhere. So it's a service that can be provided no matter where their location is. But I want to talk about respite care. I think that it's a service that people don't know about. Even I've talked to people who are on hospice, who are receiving hospice services, may not know about respite care. So talk to us a little bit about what that looks like.
Absolutely. So part of the hospice service is there's 4 levels of care. Most people think of routine home care when our staff, the care team's coming out routinely, maybe once or twice a week or those kinds of things. And then we also there may be an opportunity where if a symptom gets out of control at home, we can't manage it at home, we need a higher level of care, we might can transition them to what we call general inpatient care, which is at a contracted facility. We have a good relationship with, for instance, UAB Palliative Care Unit. If they have a bed available, we can transition our patient to that bed and help control that symptom in a more aggressive way, but the goal is still always to get back home. Yeah,
and sometimes that's for people who may need like IV medications or things like that, things that a caregiver can't do at home easily, and so they may need more like one-on-one and frequent medications. And I've seen people go in for GI, we call it GIP or general inpatient care. They go in, their symptoms get better, and they go home. I've also seen it happen where they go in and they really truly are very end of life, and they need that aggressive symptom management, and they pass away there. So it could go either way.
It could go either way, but that is a level of care that we have. But respite is one of our levels of care that, again, sets us apart from any other healthcare service, and it's available to us through hospice. The idea of respite is to give the caregiver a short break, but it's consecutive. We have contracts with local nursing homes, skilled nursing facilities, where we relocate our patient to that facility, and hospice pays for the room and board for those. It's 5 nights, 6-day break for the caregiver. Which awesome. I know, which caregivers need, again, practice self-care, because we got to take care of our caregivers so they can continue to take care of the loved one at home. But it is definitely available under hospice. It is one of their core hospice benefits.
What about transportation to and from? Like, if you're gonna do respite care, like how does transportation to those facilities work? So
typically, if our patient's able to get in and out of their own car, the caregiver may take them. But as again we know, as the disease progresses, they may be more needing a wheelchair, a van, transport, or maybe even an ambulance transport if they're more of a bed-bound patient. So that's where our social worker is key, being part of that team, that care team for the patient family, because the social worker kind of guides that and oversees that. They'll call and for a transport, kind of set that up, but the hospice is responsible for the transport too. So there's no cost to the family if they use the medical transport van or the ambulance. So it's truly, again, a wonderful service
It
to our
is.
caregivers.
Yeah.
And a lot of people ask me, well, how frequently can respite be available? Well, that is a question back to what you should ask hospices if you're interviewing hospices, is how frequently are you allowed to have respite if you need it? Because that is, I have learned that as is offered in different times, but at ExpectCare, we have families right now who pretty much utilize it every 60 to 90 days. And that's kind of the
That's what I've seen in the past with
Consist-
other groups.
right.
That's kind of the, general
the
timeframe.
general time frame. But even if you've already utilized it and something came up, emergency for the caregiver, we still can utilize it. There's things that come up sometimes.
Right.
So there's really, Medicare doesn't give the hospice guidelines of how often we can provide it.
Right.
But it's definitely something that we believe that should be provided to the caregiver.
And I would say if you interview a hospice company and they say we don't offer respite, then go interview it. Not strike them off your list.
Absolutely, that should be top strike. Or even if they say they only offer it once a year.
Yeah, I would say, next.
Yes, I would say next. Because, if you're caring for someone 24/7, once a year is really nothing.
Not much.
Nothing. Yeah.
People don't take advantage of respite in hospice very often, in my experience. And there's a few reasons, I think. So one reason is, and I want to nip some of these in the bud and
Yes.
empower people to take advantage of it.
Yes.
One reason is they're going to a nursing home. Mom said she never wanted to go to a nursing home. There's no way I can do that. Okay, let's talk about that. So these are facilities that you all are contracted
Yes.
with. You all have a relationship with. And let's just be real here. The facility's gonna be on their best behavior when they know they have one of your patients coming in, because there's a relationship there. They know there's a hospice nurse who's coming in to check on them, or someone from the group daily while they're there. It's not the same sort of experience as it may be for other people who are, that's just the realistic nature of it. It's a different experience. You also have the hospice company who can advocate for them in a way that other people may not be able to.
Right.
So
Absolutely.
I would say I understand that concern that people have, but it's not the same. You have hospice on your side to be able to facilitate that and for your loved one to really truly receive good care.
Right. Absolutely.
You also people get worried that their loved one is not going to do well in another environment, and that is certainly understandable.
Absolutely.
What I have seen though, anecdotally, is that people really do fine. Honestly, the patients usually do just fine. Some of them may not know any different.
Right.
Some of them who do are okay and don't seem to be, I haven't seen anybody in my time who's been distressed because they were necessarily in another environment. That they're also in another environment that is conducive to, providing care to patients, which is what they need. So don't say, well, my mom, she won't do it, she won't do well. I mean, even if you need to do a shorter, I'll tell people, do a short time frame. Maybe you don't feel good about 5 nights.
Sure.
Send them away for 1 or 2
Start-
and stay at home. Don't go out of town. And that way, if something goes down or it really doesn't go well, but do a trial run, do a trial run. So I recommend that people do that. But really, I mean, people really do fine with it.
They do.
It's been my experience.
Yeah, mine too. Most of the time, majority of the time, they have a great stay, great experience, and I think too. Our goals are always to help the patient remain in their home as long as possible. That's the hospice goal. That's the patient's goal. That's the caregiver's goal.
Yeah.
But there's sometimes things happen that caregivers may need to transition their loved one for
Sure.
long-term placement
Right.
into a skilled nursing home,
Yes.
and that's okay.
It is okay.
It's okay,
Yeah.
and hospice can help with that.
That's right.
And if they've had those experiences with respite, you know, they already kind of understand what that environment may be like, atmosphere may be like. The facility has already met the patient and family and already building that relationship. So sort of like, to your point, just start small.
Yeah.
Just use a night or two, see how well your loved one does,
Yeah.
how well you do.
How well
the
you do.
caregiver.
That's right.
That's a lot of times it's more about the caregiver.
Yes.
You know, because they deal a lot with maybe guilt or you know, just worry and fears about sending their loved one out of the home.
Right, and they have a responsibility to that person to make sure they're cared for and how, you know, and like they also, I mean, I think people think like, well, I don't want to send them there and they get screwed up and then they come back and I've got this whole mess to deal with. It won't even be worth the break I got, you know? I mean, I'm not a caregiver, but I imagine that's how I would feel too, you know?
And that's why you rely on your team, your nurse, your social worker, and your chaplain to help with these transitions to respite, or even to long-term placement if that's needed. And more into down the road, the hospice can go with you.
Yeah,
you know.
That's right.
And I always say if you have a loved one in a facility, whether it be a nursing home or assisted living, group home, whether it's for respite or long-term placement, it's always good to have extra eyes on your loved one. You know,
oh gosh,
have you know your hospice team there advocating for your 100%. Loved one. You know, supporting you along that journey. So
absolutely.
But we got to take care of our caregivers, whether that's through the volunteer providing a short break, you know, they're non-medical, but they can still provide a caregiver a short break in the home or through respite, because we want to support that caregiver.
Absolutely.
You know.
It's part of the holistic care approach.
Absolutely.
And I think that when we can support the caregiver and we can make sure that they have a break and are able to take care of themselves, then that is how we can keep people at home for long periods of time. You know, we see caregivers who don't just burn out emotionally, but I've seen caregivers get sick and die.
Yes.
I mean, just to be frank.
Absolutely.
You know, and people will say, well, that's not going to happen. I mean, we don't know. That's not up to us, you know? So, like, being proactive, like, being open-minded. I say on this podcast all the time, like, be open-minded. Like, don't just say, no, that's not going to work for us. Like, you know, if you have fears or you have concerns about something, whether it's hospice or respite or anything, like, find someone you can trust to talk through that with. Like, your concerns are valid, they're important, but don't just put them to the wayside and say, we're not doing this. Like, be open-minded for yourself. So
absolutely. I love that. That's kind of what I always tell families when they're considering hospice is, you know, try it. Be open-minded, like you said, but try it for 30, 60 days to see. You will see a difference of support.
Yeah.
The holistic care that we're talking about and the comprehensive care, you will feel and see the difference that hospice provide than you had in the past.
Sometimes people get better on hospice.
They do.
And there's been some research done, and I can't quote it for sure, it might be 100 days. I think people who have chronic end-stage illnesses live typically up to 100 days longer than those who are not on hospice. And that right there speaks to like how good it is for people when we stop doing shit to them and we start doing stuff for them.
Right.
You know what I mean?
Absolutely.
I mean, it just makes sense.
Well, in that same study that you're referring to, it, you know, when they're talking to the families, they report, which contributes, I think, to the extended life, because they report when they're on hospice, better communication, better symptom management, and obviously improved quality of life. Because I always say, I would want us to manage your symptoms so well that you're having a good day on hospice care, where you can go out and with your family, you know, whatever you want to do today.
Yeah.
You know, whether you want to go fishing, or you want to go out to eat with your family, or you want to go to your church service. Instead of being in the hospital for months on end, or instead of being in your doctor's office all day long and then taking a week to recover just from that one event, trying to get to the doctor's office.
Yep.
And I think, you know, because hospice can provide that level of care, they can live longer.
Absolutely. Yep.
Because they're having a better quality of life.
Yeah. Totally agree. Totally agree. I mean, I agree, and I've seen it. Like, that's been my experience, and that's why when I first became a nurse practitioner 11 years ago, I had no idea. I didn't know anything about hospice. I did not know what it was. I didn't know. I literally knew zero. And I learned a lot over the years from people like you and other people in the community that I've learned from, that I have a tremendous amount of respect for. And very quickly I saw what it did for my patients, and I was just like, I'm sold. Like, I'm sold. I get it. Like, this is it's the right thing to do. So, and also another thing is, like, you're not married to it, is what I tell people. So I know that change is hard, especially like our healthcare system is like so discombobulated and fractured, and like we really make the healthcare experience and the trajectory of aging very hard for people. We do not make it easy. Our healthcare system doesn't. We fail them in so many ways. We don't even have enough time to talk about all that. But they, we fail them so much, and it's hard for them to make a change. It's hard for them to maybe even trust a provider to recognize a change needs to be made. And so what I tell people all the time is, like, you are the one in control here. Like, we're not married to this. If we do hospice and it's not working, you come to me and let's talk through it. Let's see if there's another plan. Let's talk about what is not working with this. Like, let's have a conversation. Like, don't take it off the table. Be open-minded. You know, like, don't do that to yourself. But, you know, and there are instances where people will come off hospice because they do need to seek aggressive therapies. Ideally, and hopefully that isn't the case, but it does happen. I mean, just realistically.
It does happen.
And it's still it's an option. So, like, if you are, you know, chugging along on hospice and something comes up and you realize you need to be hospitalized or have a procedure or surgery, you can come off hospice to do that. You know, it's going to be nuanced, and like, it's not like we just want people coming on hospice all the time. Like, in an ideal world, that wouldn't be happening. But it does. So, like, just know, like, you still have options. Like, even when you're on hospice, the purpose is to surround you with so much good care and so many good people that you don't need to go to the hospital and you don't need to do all those other things. And you can focus on, like, getting the care that you need and deserve exactly where you're at.
Absolutely. Yeah, I think what I always tell patients and their family is, you know, things change on a day-by-day basis.
Sure.
You know, if your goals change later down the road, we'll address it.
That's right.
We'll make sure you know what your options
It's an
are.
ongoing conversation.
It's an ongoing conversation, and you have the right to change your level of care.
Absolutely.
All the time.
That's right.
And there are situations where our patients may have to go into the hospital if they had a really serious fall.
Sure.
And the family decides that the patient needs the surgery and agrees to the surgery if they have a fracture or but I want people to realize is that you can still get on hospice again later.
Yeah, that's right.
And so we're still going to follow you. We're still going to have these conversations, and we can still be of help to you even after those hospitalizations or rehab stays again, if those are your goals.
Yeah.
So,
absolutely.
because it's you have unlimited hospice benefit.
That's right.
Unlimited days.
Yeah.
Okay.
It's amazing.
And so
nothing is unlimited, but this really is, in a sense.
This is absolutely.
Yeah.
And we just want to honor, the patient family's wishes
Yeah.
along the way. So however we can do that.
Last kind of thing here. I know we've talked a little bit about this going on, but like things to ask when you're choosing a hospice
Yes.
company. So a lot of times if I'm recommending hospice to a family, I will always give them the option. I'll say, do you have a group that you prefer to
Right.
use? 90% of the time they're like, oh God, no, I don't know. I have no
Yeah,
idea.
yeah.
Help me, please. And so then I will usually give them, a lot of times I'll steer them to Medicare.gov and look, and we're lucky in our area to have a few agencies, and ExpectCare is one of them, who have a 5-star
Absolutely.
Medicare rating, which is
So proud of
which
that.
is huge. I mean, you can't, that's a fact. It's not something that's, subjective, like that is a fact.
Right.
So, I'll lead people there, and then just depending on maybe what their needs are, where they're located, or I may make a recommendation based on a group that I'm aware of or have a relationship with. And a lot of times people will want to go and kind of research, they'll want to talk to the community educator, they'll want to get to know a little bit more about that group and kind of pick someone that they have a good feel with, which I think is a great opportunity if you can do so. And a couple of things to ask that person, and one is respite care.
One is respite.
What's your respite availability? We talked a little bit about that, and understand what that looks like. And another is volunteers. So what do volunteer services look like? How many do you have? Like, how often can I get that service? What are some other things that you think people may need to ask that might help them make a decision about which group is best for them?
Absolutely. I think some of the other questions that I always ask, have families ask is, do you get to keep, like, with your hospice, do you have assigned nurses? Because it's,
That's huge, yeah.
or, ask them about their staffing to patient ratio. How are they doing with their staffing? Do we have a, consistent nurse that will be coming routinely? Because our goal at ExpectCare is to have a nurse that's assigned, to the patient and family throughout the duration of their care, so that we can have that continuity of care.
Very important.
Very important. I think, so ask about their staffing and will they have an assigned nurse. I think also asking about kind of their on-call, how's on-call, like after hours approached? Do they have an on-call team? Kind of what is your goal for response time with the on-call after hours and weekends? What can we expect? What would that look like? And additionally, I think also is ask about their bereavement services. Bereavement is a core service. We have a bereavement manager and coordinator that's part of the care team after the patient passes away, that will be there for the caregiver to help them through their grief and their, journey, grief reconciliation. At ExpectCare, we have grief support groups, asking about what does that look like in your bereavement services?
Right. Yeah.
What can we provide after that event? So those are some of the kind of the top 4 or 5 that a lot of families are asking me, and that I encourage them to ask when they're interviewing other hospices. But you mentioned one, star rating. Go to Medicare.gov, because that comes from the families. The families have rated their experience and how well did we manage their symptoms, their pain, how accessible they felt like we were, after hours calls, and all those things. We're questioned. Medicare sends out a survey after the patient passes away to the caregiver, and they can say whatever they want to say about their time and service on hospice. But I'm so grateful that we have a great team and a great staff that they have rated us a 5-star.
Yeah, I love that.
Yeah.
That's awesome.
Absolutely.
I would also ask maybe a little bit about the medical director, if you wanted to know that.
Sure. I do get that
what
question.
their experience is, what their level of, what their comfort level is with treating someone with, such and such illness. And then we didn't mention this. There's so much good stuff to mention about hospice. Like we could talk we could literally talk all day. And Taylor's probably like, "Oh my gosh, I gotta wrap it up." But supplies. So
yes, we did. Yeah.
part of the hospice benefit is personal care supplies being provided. So that is included.
And equipment.
Yes. So that may look like oxygen, a hospital bed, a bedside commode, a shower chair, a bedside table. And those are things that just because you're on hospice you can get. Like you don't have to meet certain qualifications. Absolutely. You don't have to go through like a bunch of paperwork to get it. Authorizations like if I send a hospice referral for so and so today, they could be admitted today and get equipment today. There's no hoops to jump through. Also supplies, so like incontinence supplies, so diapers, chucks, bed pads, wipes, gloves, all of those things.
Absolutely.
And it's different hospice companies may do that different in the amount and things like that. That would be a question.
That's a good question. Yes, that's a good question. And then medications that are related to that hospice diagnosis. So if you have congestive heart failure, then some of those medications are covered. I would do that too. Gosh, I would. Man, you would want to talk to me if you were going to have to do a hospice company. But maybe give them a med list and say which of these things are covered, because that can make a big difference for people too. Like just cost wise and things like that. So in any medications that are related to symptom management, or infection or pain or constipation or shortness of breath or anything like that, nebulizers, all of that is going to be covered under your hospice benefit as well, which is huge. It's huge. It's a cost savings for the family.
Yeah.
Because hospice is providing, as you said, supplementing the incontinence supplies, providing the equipment. There's, and also some of the medications. So again, there's no co-pays.
Yeah.
So anything that hospice does that we're providing, there's no co-pays for anything.
That's right.
So
yeah.
But that's a good question. I think you should add that to the list of supplies, because that's a differentiator amongst hospices and how the nuances of
and like if you have a certain specific diaper you like or something like that, like you're gonna be subject to the brand they provide and things like you don't have control over that. So like I've seen people get really upset about little things like that, which are big things to them.
Yes.
And but like if there's something real specific, you may still have to purchase it on your own, but like it's still a huge help to have that as a supplement. So, man, this was awesome.
Great.
I love hospice. Like it is my favorite thing in the world. I love it. And I worked in hospice for 7 years and loved every second of it, worked at the bedside, and I mean, I adore it. So I thank you so much for joining us today. Thank you for all of your incredible insight and knowledge, and thank you for everything that your team does to just take care of these people and make sure that they have the best that they deserve.
Absolutely.
I appreciate that so much.
Yeah, thank you. As I told you, I love hospice. I've been here in hospice almost 20 years, so I'm going to continue that. 20 more, I hope, before retirement. And then I always jokingly say that once I retire, I'm going to become a hospice volunteer. But it will not be a joke. That's what I will do in my retirement. I will be a hospice volunteer.
Well, that's
helping
great.
at bedside. But thank you for allowing us to be here today. I've enjoyed, I always love talking about hospice and helping families through it. But appreciate y'all letting us take care of your families when that's needed. Needs arise. So glad to be here today.
Absolutely. Well, thank you all so much for joining us. This was an exciting conversation. I hope you all learned a thing or two. Remember to stay open-minded, as I like to say. And then be sure to like, share, subscribe, send to your neighbor, send to your sister, send to your friend, whatever you need to do. But thank you so much for joining us on Aging Uncensored today.